So I'm going to go straight on with the second presentation, which is mimics of soft tissue sarcoma. And if you have questions from the first presentation or um, obviously anything coming up in this presentation, you're very welcome. We'll take questions after this talk. So what is the issue here with mimics of sarcoma? Well, there are a remarkable number of discrepancies are found in diagnoses at referral centres compared with those of the referring pathologist. This is no reflection on the quality of the referring pathologist. It's simply a matter of unfamiliarity, usually with a very difficult field, because sarcomas are best handled at a specialist centre with a multidisciplinary team. Dr. Sway and I, between us, probably see about 4,500 soft tissue tumours a year. But most pathologists will see 1 or 2 sarcomas a year at the most. So it's not surprising that when they're sent to the referral centre, there are differences in opinion. On the other hand, it's interesting to see over a period of, 40 years, how consistent this has been and how even the advent of molecular pathology, immunohistochemistry, and awareness of tumor types has made very little of a dent in the figure of 25% approximately discrepancies in diagnosis. There are also quite persistent discrepancies in grade, which is perhaps more difficult, particularly on a core biopsy. So there is a need to look at these very carefully and find out whether we can sort of reduce this a bit. Of course, the biggest issue, grade perhaps being less important in a way, the biggest, or even diagnosis being less important, but the biggest issue is benign versus malignant. Excuse me. The French sarcoma group, who have a very good arrangement whereby all tumors are centrally reviewed, looked at a large series of 2,425 patients and found only 14% had received a discordant diagnosis, which is interesting because it's still quite a high number, even in a very sophisticated system. And that some of those were benign tumors diagnosed as sarcomas, particularly fasciitis and fatty tumors, and that quite a few were non-sarcoma malignancies, which were diagnosed as sarcomas, carcinomas and melanomas. So these are some of the areas we should look at. But there are also quite a few more tumors, as you can see here, which cause a problem, and these are atypical or not atypical or rapidly growing, and we need to look at these now in some more detail. Let's start with our old friend nodular fasciitis. And this is a relatively common tumor that occurs in young adults, mainly limbs and trunk, but also head and neck. It grows rapidly, and therein lies the suspicion, because it could take in a week, it could grow to 2 or 3 centimeters. So obviously, the patient and the clinician are both very alarmed that this is a sarcoma, although it does tend not to go bigger than 5 centimeters and to stop growing. It can be at any level. This specimen is very unusual. This is a benign lesion. Why would you take out a huge chunk of tumor like that, of tissue like that? Well, here is the needle track. Excuse me. And we got this needle core biopsy, which we diagnosed as nodular fasciitis, and the surgeon said, I don't believe you, it's grown very rapidly, I'm going to take it out as a sarcoma. So this is the only nice specimen I have, gross specimen of a complete nodular fasciitis. But you can see it's sitting nicely on the fascia here and growing up into the subcutaneous fat. It can also occur in the skin. It can occur in the fat there. It can actually sit on the fascia, or it can be on the other side of the deep fascia as intramuscular fasciitis, which is even more treacherous by mimicking sarcoma because it's deeply located and you have a higher index of suspicion. Nodular fasciitis has a series of patterns which represent evolution of the lesion. It starts as a bland myxoid tumor with spindle and stellate cells dispersed in myxoid stroma, often with little hemorrhages. Then it becomes more cellular, lymphocytes are extruded. Note these small myxoid microcysts with a curiously shaped edge known as the crescent sign. And, excuse me, the varying cellularity with these looser spindle cells forming larger storiform whorls that increase, and then gradually fibrous bands form, collagen is deposited, and the tumor becomes less cellular and more. And this pattern of shredded carrot almost, although we use that for nursery tumors, the shredded carrot collagen is very characteristic of a later stage fasciitis. This evolution is important, as we'll see when we look at the molecular features. And later on, you can get giant cells, which can often compound or make more difficult the diagnosis. So, immunohistochemically, smooth muscle actin is the marker of choice. And note that this is typical myofibroblastic pattern of deposition of the chromogen. It is subplasmalemmal in a linear fashion like that. So it outlines the cell. It's not throughout the cytoplasm. If so, it is more characteristic of smooth muscle. Calponin is also positive, but caldesmon is usually negative. Heavy caldesmon is usually negative in myofibroblastic lesions. Now, molecularly, nodular fasciitis, although a benign neoplasm that grows and then disappears or shrinks and becomes a fibrous nodule, is actually a translocation-associated neoplasm. And the genes involved are ubiquitin-specific peptidase 6, which is rearranged with one of several partners, which the most common is myoglobin heavy chain 9, MyH9, and then increasingly new partners are described every month, and I've listed some of them here just so you know what's going on. Notice, however, that not all nodular fasciitis are posited by FISH. You can, or at least to say, you cannot detect the split using the break-apart probes. And very interestingly, a paper recently from Hungary has shown that the number of signals is related to mitotic count, and the percentage is reduced in older lesions. And of course, this makes sense because the older lesion is undergoing, if you like, atrophy or apoptosis of the cells, and so the signals disappear. So this may be why a proportion of fasciitis are FISH negative when you do the test, because they're older lesions, and it's always useful to know the duration of the lesion. You generally tend not to get it. If it's short, you get it, like it's been there a week or 2 weeks. But if it's 3 or 4 months, then that may not be a great deal of help because the history is imprecise. At any rate, it's interesting to know that, that this can happen, and also useful to know that a negative FISH does not exclude the diagnosis. Also, a positive FISH does not necessarily confirm the diagnosis because this gene is also rearranged in several other tumor types, some of which we will discuss shortly. So there's a summary of the features, the zonation from myxoid to cellular to fibrous as the lesion evolves, the storiform pattern, and typically no pleomorphism, no abnormal mitoses, although you can have plenty of normal ones, and no necrosis. However, unfortunately, atypical and malignant variants have recently been described. Atypical nodular fasciitis has been described, resembling the cellular variant in this case report, with a different partner, and also fasciitis with highly malignant morphology, looking like a pleomorphic sarcoma here, and this is from this paper by Dr. Thomason and colleagues. Has been described also, and this is in an infant, and the follow-up is there's no recurrence or metastasis in 22 months, and the gene was the collagen 6A2 with USP6. Why would we call this fasciitis when it looks like this? Well, first of all, it's got the USP6. Secondly, it behaves like fasciitis, and I think this is a very important issue here of how we name tumors, because in the old days, without the molecular, we would have probably called this a high-grade sarcoma in an infant, and he may well have been radically treated. But in this case, the USP6 gives the clue to what it should be called, although I must admit, you have to have a strong character to stick to your benign diagnosis here. In addition, there have been a couple of reports of frankly malignant nodular fasciitis, which did metastasize or caused extensive local invasion with necrosis. And both of these, interestingly, had the triple P6R3 gene fused with the USP6. So again, should these be called fasciitis? Again, based on the USP6, and in one case, or both cases, the typical morphology, at least to start with, this is how this terminology has been retained. So there is another perhaps reason for doing the NGS on fasciitis, particularly if it looks a bit unusual, is to identify this particular fusion which could predict malignancy. What about differential diagnosis of nodular fasciitis? So we have listed here cutaneous fibrocystiocytoma is the first one. It can arise fairly deeply. So, for example, in sorry to be looking aside, but I get messages coming in about the presentation, so I'll just get slightly distracted. I apologize. By the way, can I remind you, you're very welcome to send questions via the chat facility, and we'll take them at the end, so feel free. So cutaneous fibrocystiocytoma, and this is another myofibroblastic lesion. This is a cellular variant here showing you the parallel aligned, very uniform fibroblasts in this case. Notice the pattern of invasion. It's by pointed prongs into the subcutis, and these are often said to be radial rather than tangential, which is a feature of dermatofibrosarcoma. And also, at the periphery of the cutaneous fibrocystiocytomas, dermatofibromas, you often get thickened collagen bundles which are infiltrated by the lesional cells, as seen here. Also in the differential is fibromatosis. In the earlier stages, fibromatosis is more myxoid and can resemble fasciitis. Of course, a fully developed lesion is very typical. We've seen it a number of times already this morning, today, and it should not be a problem. You do a beta-catenin, or if you need to, you will do a FISH for USP6, which will of course be negative. You can also do mutation analysis for beta-catenin gene mutation. Fibroma tendon sheath can look very similar to fasciitis, and indeed has a cellular variant that is indistinguishable from fasciitis. It's clinically, of course, distinct. It affects tendons on the extremities. It's a circumscribed lobulated tumor, and there is indeed a pleomorphic variant also. There is the bland look of it, and here's the pleomorphic variant. But all of these, or most of these at any rate, have USP rearrangement on FISH, just like nodular fasciitis. So if you see a fasciitis-like fibroma of tendon sheath and you do the USP6 and it's rearranged, FISH, is this fasciitis? Well, it depends on the clinical context. And by the way, although in fibroma tendon sheath the MYH9 is the usual partner, all of those listed, and it's getting to be almost anything probably eventually, can be a partner in this. So the FISH, however, is diagnostic, and most of us are not going to be looking for the partner gene except for academic interest. Desmoplastic fibroblastoma is another tumor that can occur in subcutaneous or deep soft tissue, slowly growing in contrast to fasciitis. It's circumscribed in contrast to fasciitis, and it's very sparsely cellular with scattered stellate or spindle cells in this rather uniform hypocellular collagen. The genes for this are not certain yet for fusion. It does have genetic abnormalities, but it doesn't have a USP6 rearrangement. It was postulated at one point that this was the end stage of nodular fasciitis. It might be because the USP6 would disappear at this stage. At any rate, it's quite a distinctive tumor. Now, nodular fasciitis versus low-grade myofibroblastic myofibrosarcoma. The myofibrosarcoma is more cellular, as you can see. It lacks the inflammatory and myxoid component. It has typically random pleomorphism, and it can also have necrosis, even when it looks quite bland. Although this looks bland, notice a little bit of atypia, and notice the necrosis. And this low-grade myofibrosarcoma, nodular fasciitis-like, actually metastasized. There are unfortunately no specific genetic changes for this tumor. Now, nodular fasciitis versus leiomyosarcoma, when you see them side by side, there's no contest. The leiomyosarcoma has rectilinear fascicles, blunt-ended nuclei, paranuclear vacuoles, shown here. And, of course, the immunohistochemistry is different. This has strong desmin, strong caldesmon, as well as the SMA, which is seen here. Notice, by the way, these typical microcysts. Nodular fasciitis versus mixed fibrosarcoma is fairly easy because the mixed fibrosarcoma has not only the vessels, but it has atypia by definition, and it's random atypia with bland cells. Theoretically, in the core biopsy, you might miss all the atypia, but you're more likely to call it a myxoma than a fasciitis. And of course, in mixed fibrosarcoma, you can merge into more pleomorphic areas, and this can be increased on recurrence, grade progression. Now, what about subtypes of fasciitis itself? So, the usual fasciitis is nodular. There's cranial fasciitis, which is a sort of infantile variant. There's intravascular fasciitis. They're all very similar. Proliferative and ischemic fasciitis are quite different entities. Intravascular fasciitis is rare. I think I've only seen 2 or 3 over many years. Perhaps they're not biopsied, or perhaps we don't know it's intravascular because the core biopsy only shows the fasciitis. Extremities, head, neck, and trunk, involving veins or arteries, and it can be transmural or luminal. Here's one filling the vessel, I think a vein, and you can see the different patterns of the fasciitis within. This is one of the few types of fasciitis that recurs, probably because it's incompletely excised. It can be quite aggressive. Notice how this one is actually chewed through the elastic lamina of an artery and gone out like that. So do not underestimate it. And this, of course, also has the USP6, and examples that have been investigated have shown beta-catenin as a partner. Now, proliferative fasciitis is a very different entity in a number of ways. It does have a fasciitis-like background histologically, but it also has these large polygonal cells, not really with significant atypia, but with occasional mitoses and relatively abundant cytoplasm. Like nodular fasciitis, it grows rapidly and then reaches a point where it stops. It's in the same clinical context, perhaps a slightly older age group. Like fasciitis, there's said to be a history of trauma, but in fact, I've almost never seen any cases with that history of trauma. Maybe it's incidental trauma. Also, many of us have lots of traumas and don't develop proliferative or nodular fasciitis. And this also differs from nodular fasciitis in having a FOS gene rearrangement with fermentin gene, and this is a fairly new information, so more information may emerge as more cases are genetically analyzed. Notice the fasciitis-like background with these scattered cells. Proliferative myositis is proliferative fasciitis in the muscle, essentially, and you can see how it dissects between the skeletal muscle bundles with a similar cellular composition there. Excuse me. And there's a big muscle fiber, and this is sometimes called a checkerboard pattern. This is relatively easy to diagnose because it's completely negative for all the markers. It has the same fusion as proliferative fasciitis. Because all the markers are negative, that makes the differential diagnosis fairly easy, although it is a wide one. And I have seen each of these diagnosed when it really was a fasciitis. There, if you, as a reminder, are the immunos you can use in each of these examples to help you diagnose these, and if they're all negative, consider the fasciitis again. Look at the background, look at the history. Now, ischemic fasciitis isn't really a fasciitis, but it's termed this, and it actually got 3 separate names to start with, but this is the one that's now approved, and this typically was in elderly patients who were immobilized. So they're lying there and they got a lump at the site of lying, where they were lying on, usually over a bony prominence, such as the sacrum, greater trochanter. The lesion wasn't ulcerated, it's not a bed sore, it was in the deep subcutis as a painless mass. Since then, they've been described without this clinical context and in younger patients. It's very characteristic on a core biopsy. It has this fibrinoid necrosis of fat without marked inflammatory response. And here it is at the edge of the fibrinoid, and you can see proliferating capillaries and then scattered large atypical fibroblasts. usually few mitoses, and usually without nucleoli. Those are those features. This is another zonal tumor. Histochemically, not very exciting. You can have a bit of SMA, a bit of desmin, a bit of CD34, but the morphology is very characteristic. And if you ring up the clinician, or you today, you'd have to email or text, you will get an answer saying, yes, this patient has been lying, is immobilized, in some cases. Okay, so that's the fasciitis group, which is an important group of mimics of sarcoma. Let's go on to look at now a group of tumors that form bone. So ossifying fasciitis, there's a nice radiograph. It's simply nodular fasciitis with bone formation. And this has a nice zonation, as you can see here. The bone is metaplastic but benign, and you can see it's almost forming a shell at the periphery, tending perhaps to mimic, in some cases, ossifying fibromyxoid tumor. Another lesion that's similar is fibrosis pseudotumor of digits, which can occur in, again, with this history of trauma, and it really belongs to the same group as nodular fasciitis. It has USP6 collagen 1A1 fusion, and it stabilizes or regresses in the same way. And this has a zoning pattern. You can see the bone forming in a sort of reticulated pattern out of the fasciitis, the bone being benign, and sometimes there is also cartilage. And you need to be careful that you don't mistake this for chondrosarcoma. Myositis ossificans is a similar type of tumor, which has actually the same fusion, and there's also the same fusion found sometimes in aneurysmal bone cysts of soft tissue. Aneurysmal bone cyst. So it's been suggested this is an aneurysmal bone cyst of soft tissue. It doesn't matter, regardless. The important point is not to overcall it as malignancy. Again, it has the typical rapid growth, the trauma history sometimes, the zoning, and metaplastic bone with giant cells and cartilage. Here it is, disrupting and forming bone within the muscle. Here's the skeletal muscle. Here's a shell of bone. There's the fasciitis-like area. This shows quite a large chunk of cartilage in these needle core biopsies. So cartilage can also be a feature. The principal differential for these ossifying benign lesions is extraskeletal osteosarcoma. This occurs in an older age group in the extremities. Some will have a history of radiation, therapeutic radiation, and it can also occur as a heterologous component in dedifferentiated liposarcoma, malignant peripheral nerve sheath tumor, and carcinomas. It's an aggressive neoplasm, and the histological subtypes are the same as in bone. Here is an extraskeletal osteosarcoma showing you malignant bone formation. Look at the cytology, and malignant cartilage formation in this chondroblastic osteosarcoma. So the distinction should be fairly straightforward based on the cytology as well as the other features. But one does see overcalling of these benign ossifying lesions. So just bear everything in mind when you're making this diagnosis. Now, a couple of entities that have been recently described and are of somewhat uncertain nature. Massive localized lymphedema of the morbidly obese. I'm not sure that this terminology is okay today, but this is what the tumor was called originally. And this occurs in very large patients and forms very large masses. So the mean body weight of the large series was 400 pounds, 186 kilograms. And the mean weight of the tumor mass, which formed mainly on the thigh or the legs and sometimes the abdominal wall, was 7 kilos. Now that is bigger than most intra-abdominal liposarcomas, which can be pretty big. Very rarely it becomes malignant, but mostly it is not. And this has a rather distinctive appearance with expanded septa, interlobular fatty septa, expanded by edema. And this chronic edema provokes perhaps proliferation of small blood vessels, capillaries at the interface. There's no atypia. You might be fooled into thinking of myxoid liposarcoma or atypical lipomatous tumor, which can have a similar pattern on low power, but the fibrous septa, more resembling the fingers of a glove, are fibrous. They're not edematous. And within, you can see even on this low magnification, there are scattered atypical cells. So it should not be a problem. The first case I ever saw of this, I misdiagnosed, and turned out we got it right in the end. Soft tissue angiofibroma is another relatively new entity. Benign fibroblastic neoplasm, I think actually 2012, is that relatively recent? In the last decade. Benign fibroblastic neoplasm, mainly lower extremities near to joints, but also in the trunk, and generally subcutaneous, but can be deep. This is a circumscribed tumor, which has a rather uniform, bland spindle cell makeup, and the cells are dispersed fairly uniformly in a fibromyxoid stroma with a very prominent vascular network. There's no cytological atypia, although sometimes it's degenerative atypia, and the immuno is not very conclusive. There's sometimes some CD34, some epithelial membrane antigen, some SMA or desmin, also in scattered dendritic cells. S100 protein negative. This has a genetic, defining genetic feature. It has fusions, usually the AHRR with NCOA2, but more recently, examples with the GAB1, ABL1 have been described. How does this mimic malignancy? Well, it also mimics other benign tumors, which we'll look at. So you need to exclude solitary fibrous tumor, mix of fibrosarcoma, no atypia. Cellular angiofibroma tends to occur in the pelvic region in males and females. It has more vessels, which are thicker with thick walls, or more dilated with thick walls, can have a component of adipose tissue, is often CD34 positive, and has RB1 loss. And when you see them side by side, it's not a problem. They're both benign, so in that respect, it's not too significant. But the important distinction and why it's included in this presentation is from myxoid liposarcoma, because the vascular pattern in soft tissue angiofibroma can make you think of the vascular pattern in myxoid liposarcoma. In fact, it differs a little bit. They tend to be more joined up in myxoid liposarcoma. The cells tend to cluster around the vessels. There is lipoblast formation of varying degree. And of course, you have the genetic defining fusion. Cellular schwannoma also can be a problem in diagnosis, particularly in intra-abdominal or intrathoracic tumors where they occur and often pressed up against the vertebra. And a particularly favorite site is the curve of the sacrum behind the uterus, and it presents to gynecologists. This is not associated with neurofibromatosis type 1, although there's often a nerve going in. There may be just a tiny bit of it here. Notice it has a very thick capsule, which is important for diagnosis. It can be quite large. It can erode bone by pressure. You can see a compressed or rather eroded and curved in vertebra, but that does not imply malignancy. Typically, it has a fascicular uniform architecture, but there can be atypia, either scattered in spindle cells or more pleomorphic in this way. But notice the lack of nucleoli and the lack of atypical mitoses. Another feature of cellular schwannoma, which is often helpful at low power, is the presence of clusters of foamy macrophages. Immunohistochemistry causes diagnostic diffuse S100 protein, sparing in this case the blood vessels. Peripherally, under the capsule or within, there are EMA positive perineurial cells, and there can be GFAP positivity scattered through the tumor. A subset, particularly retroperitoneal, have cytokeratin positivity. It's possible if revisited, some of these are myeloepithelial tumors. But the mimic is for malignant peripheral nerve sheath tumor. So the capsule is a useful feature. It's not associated with NF1. Any atypia is only focal and does not have atypical mitoses. The immunohistochemistry is uniformly positive, SOX10 and S100 protein. You have the perineurial cells in the capsule, and there's no loss of H3K27. When you get malignant change in schwannoma, it's usually epithelioid MPNST, although occasionally spindle cell. And it's a little bit treacherous because epithelioid MPNST, unlike spindle cell, does not lose its markers. It stays S100 positive and so on. But you tend to get larger cells, more abundant cytoplasm, prominent nucleoli, and they tend to stand out in the schwannoma as a focus. You can also have, very rarely, angiosarcomatous change in schwannoma as depicted here, usually epithelioid angiosarcoma. Now, a couple of tumor types with atypia, which can mislead you. Atypical cutaneous fibrocystocytoma, and this is a fibrocystocytoma. It's often polypoid in the skin. It can extend into supple superficial subcutis, and it can occasionally recur, but it rarely metastasizes. The ones that metastasize get written up, but there are no histological predictors, so you can't tell which ones are metastasized. Here are the morphologic features showing you quite a large tumor. Notice the typical FH features, the cutaneous FH with the radial extension into the subcutaneous fat. Notice the background of usual fibrocystocytoma, in this case cellular, but with scattered pleomorphic cells, either spindle, more polygonal, or with foamy cytoplasm. And these variant appearances can be seen in the same tumor. The key feature being the presence of non-pleomorphic cells between. In other words, it's not throughout. Here's a summary of those features, with the mention also epidermal hyperplasia that is seen, the hemosiderin and the multinucleated cells, just features of cutaneous FH. You may see atypical mitoses, not in themselves denoting potential for metastasis. Immunohistochemically, there's not much to go. Smooth muscle actin and very rarely some CD34, which gives you a whole other bunch of problems. This needs to be distinguished from atypical fibroxanthoma, which is also a benign tumor, as I mentioned, in the sense that it does not metastasize if it's confined to the skin. But this is pleomorphic throughout, and it differs in that sense from dermal cutaneous, atypical cutaneous fibrocystocytoma, and you can see the frequent abnormal mitoses in this tumor type. Immunohistochemically, well, CD10 is a non-specific marker, but I suppose if it's absent, you might think again, and a bit of SMA, but by definition, of course, it does not have any other lineage markers. Now, I mentioned earlier pleomorphic dermal sarcoma. This is the deep counterpart of AFX, and it occurs in the sun-damaged skin of older patients, usually males, and that's to say on the head. Best to try and keep some hair, I think, in this situation. And it has some changes, genetic changes, which are not of diagnostic value. Again, a pleomorphic tumor. It's like it's used to be called a superficial MFH or pleomorphic sarcoma, and this is a fully malignant tumor when it invades deeply with 28% recurrence, 10% metastasis. If you can get it all out, it will do better. The margin status is predicted. Now, another tumor with scattered atypia, but deeper than the skin, is the superficial CD34 positive fibroblastic tumor, reported in quite a large series not that long ago. Mainly in the lower extremity, in the deep dermis and subcutis of young adults, this tumor can recur but does not metastasize to date. And that's important because the morphology includes quite a degree of atypia. There are spindle to epithelioid cells in sheets with focal nuclear atypia. Nuclear inclusions are a feature, as well as an inflammatory infiltrate. Mitoses are usually sparse and no abnormal ones are seen. This tumor is CD34 positive, hence the name, and also has sometimes focal or scattered cytokeratin positivity. There are no specific genetic changes yet described in this tumor. This, of course, gives a wide differential, some of which we've discussed already, and others we will discuss shortly. A very similar tumor at the bottom is the PRDM10 rearranged soft tissue tumor, described in a couple of years ago in a multi-center study of 9 cases. And this is characterized genetically by fusion of PRDM10 with a variety of partners, MED1, 2, or CITED2. And these were discovered as a subset of undifferentiated pleomorphic sarcomas, but in fact, they differ because they're not pleomorphic throughout. Adult tumor, superficial or deep, usually small and circumscribed in various locations. Again, one recurred and none metastasized. Here's the morphology, fascicles of focally pleomorphic cells, somewhat resembling the superficial CD34 positive tumor, although having myxoid stroma and metaplastic bone in some cases. Also CD34 and cytokeratin positive, sometimes with desmin. And in fact, it's been recently, this year, suggested that these two entities, superficial CD34 positive fibroblastic tumor, PRDM10 rearranged soft tissue tumor, are overlapping entities. They looked at 10 of each and they found a lot of similarities, except the PRDM10, as mentioned, has myxoid stroma metaplastic bone, similar immunophenotype. And of course, the PRDM10 rearranged tumor has rearrangement of PRDM10. This is not found in the other one. Now, finally, in this atypical group, pleomorphic hyalinizing angioectatic tumor. This was first described in, when did we do this? 1996. In some cases, mainly from Dr. Weiss's group. And it's usually, or at least in the earlier cases, it was an extremity tumor, but it's now described in other places, including chest wall. It's usually not very large because, being superficial, lumps are discovered earlier, so deeper ones grow bigger before they're discovered. And some of these recur but do not metastasize. It's a very hemorrhagic circumscribed tumor, as you can see on this growth illustration. And histologically, it's quite distinctive. It has clusters of thick-walled vessels, which are ectatic, hence the term dilated, and have fibrin insudation outside, which can hyalinize, so they have these thick pink walls, and they often have striking intranuclear inclusions. Scattered throughout are atypical cells with pleomorphic nuclei, but hardly ever with nucleoli or mitoses. There's lots of hemosiderin, scattered mast cells, and they can be CD34 positive. It's quite distinctive, and it's the atypia that gives you a problem, but the differential really is mainly with pleomorphic sarcomas, the features are lacking, or schwannoma, but this is S100 protein negative. Well, subsequently in a larger series, also from Dr. Weiss and Dr. Falk, it was noted that some of the pleomorphic hyalinizing angioectatic tumors, which are known colloquially as FATs, were associated with a blander spindle cell hemosiderin-laden component. And this had already been described as hemosiderotic fibrolipomatous tumor, actually described in a different name, hemosiderotic fibrohistiocytic. But names get changed a lot in soft tissue pathology. You just have to go with the flow. It's like gene names are being changed all the time. So this occurred mainly on the foot in females with the typical complaint of "my shoe is too tight, doctor," or "the same shoe is now tighter than it was." Although it occurs in other sites, there can again be a history of trauma that there might well be on the foot with the shoe problem, and it's slowly growing. These recur quite commonly, and some have progressed to sarcomas. Histologically, this is another mimic of malignancy because it has spindle cells infiltrating fat with scattered spindle cells infiltrating fat with scattered atypical nuclei. And one of the features is the extensive hemosiderin deposition, also hence the name, which you can show with the pearls. And another feature is CD34 positivity. If you see this sort of pattern of fatty infiltrate, you might be tempted to think of dermatofibrosarcoma, particularly with the CD34, or even some other low-grade spindle cell sarcoma because of the focal atypia. But the clinical picture and the morphology with very extensive hemosiderin is very typical in this situation. Some of these tumors are hybrids with another entity called myxoinflammatory fibroblastic sarcoma, and may even be a precursor of that. And this is a tumor that again occurs on the extremities, initially foot and hand, but also now in other sites. It can infiltrate into tendons and joints. In the early stages, it's quite difficult to diagnose, and this is almost the converse. This is a malignant neoplasm masquerading as a benign one. But in the early stages, you may just see sheets of bland spindle cells, inflammatory cells, including eosinophils. But there are two clues. One is the presence of the so-called Reed-Sternberg or virucyte-like cell, which looks like indeed a Reed-Sternberg cell with a prominent nucleoli, prominent nuclear membranes, often binucleated. And the second feature is the presence of myxoid fibroblasts. in a myxoid stroma. And in the very early stages, this may be the only clue there is. You can just see this on low power here. And in the more advanced stages, this can expand and it can look like myxofibrous sarcoma. But the clue is these very large vacuolated cells. And it gives you a clue to go searching for these larger cells. And the other clue is seeing eosinophils, which may tip you off in an extremity neoplasm. This tumor can be CD34 positive, not in every case, and it's not therefore particularly diagnostic. There are no other markers that are useful. Now, these three lesions, hemosiderotic fibrolipomatous tumor, mixed inflammatory fibroblastic sarcoma, and FAT, are apparently related. They seem to have some similar molecular changes. HFLT and the hybrid HFLT and MIFS can have abnormalities in the TGFBR3 and MGA5 gene, but they tend not to form fusion genes. And other single gene abnormalities have been described. BRAF fusion and BRAF mutations have also been described in MIFS, mixed inflammatory fibroblastic sarcoma, but not apparently in the other types. And if we look at the distribution of these, we find that most commonly these genetic changes are found, at least for the TGFBR3 and MGA5, are found in the hybrid tumor, 6 out of 6, and less commonly, for example, in the FAT, which only has a very few detected changes. The BRAF changes have only so far been described in MIFS. So the precise classification of these tumors remains a subject of debate, according to the WHO, and there is lively debate, I am sure, and sometimes you hear it in meetings, but it's not clear what's going on here. They seem to be related. They're not genetically totally tied together. And does one progress to the other? Do the hybrid HFLT MIFS represent sarcomatous progression? We don't know. Watch for the next WHO book, which will probably be in about 8 years. Now, finally, remember that, and I pointed out at the beginning, non-mesenchymal tumors can mimic sarcoma. So sarcomatoid carcinoma is a common problem. If it's in an organ, liver, lung, kidney, it's more likely to be carcinoma. Look for an in situ component, particularly in the skin, for example. Look for an epithelial component somewhere in the tumor. Look for heterologous elements that give you a pointer. And cytokeratin positivity, unless it's something else like synovial sarcoma, is usually supportive evidence of sarcomatoid carcinoma. This is how to tell synovial sarcoma from sarcomatoid carcinoma. You haven't got the other factor. You've got a very uniform tumor because of translocation associated. It's not pleomorphic, no in situ component. The keratin is more focal. CD56 and BCL2 are very good markers, and there's a brand new one which I'll talk about later. Look for mast cells, which are more frequent in synovial sarcoma, and then you can do the FISH SS18. And remember those nuclear features that are quite useful, the overlapping, elongated speckled nuclei. And then melanoma, spindle melanoma can be confused from malignant peripheral nerve sheath tumor because of the S100 protein and SOX10. Look for a junctional component in superficial tumors or primaries. The S100 protein and SOX10 are more widespread in the melanoma. Both lack HMB45 melan A, usually the sarcomatoid melanoma. And you may want to do the BRAF and NRAS mutation, which are not wholly diagnostic, but indicative and are more useful for guiding therapy. There's the SOX10, which is a very useful marker, of course, for melanoma. So, to conclude, how can you not mistake a mimic for a sarcoma? First of all, get the history as always. Check the location, the duration, the rate of growth, and has there been an antecedent event. Be aware of the diagnostic possibilities. Keep them in mind. Keep a little table by your microscope. And, of course, always feel free to seek a second opinion. Thank you very much.